Well, thank you very much. And I I'm going to focus here on CGRP monoclonals. I won't really talk very much at all about GPANs. We've not had much problem with the GPANs. It's really been more the monoclonals. And the focus of the talk really is what we have to do about studies, why they miss the adverse effects. These are not bad drugs. I do use the CGRP monoclonals. My issue is where they should be put. And what I see these days, at least in the United States, is a lot of doctors are using them first before trying anything else for a headache. And I don't think that that's a great idea, and I'll explain why. I'm on a speakers board of several companies. The efficacy is held up pretty well. Short-term safety is what I'm focused on here of the monoclonal antibodies. There's a lot of adverse effects we'll get into. Long-term safety, though, we don't know. It takes years to figure out some of these drugs. And I always say use new drugs a lot while they're still safe. We just never know. But I do know that CGRP has been important since the Cambrian period for 450 million years in most animals, and we ignore evolution at our peril. So before these came out, 4.5 or almost 5 years, actually 5 years ago, was erenumab. I wrote an article about all of the good and bad things that CGRP does. And it's frightening because CGRP does a lot of good things. And I'll go over those briefly here. So CGRP is important in hypertension, in preventing more severe MI, as a vasodilator. It's important in aortic stress and worsening cardiovascular disease under stress. These drugs have not been tested under cardiac or physiologic stress. We can see worsening cardiac disease without CGRP, and it has protective effects on the myocardium. So we just haven't tested these. Going north to the brain, could lack of CGRP lead to more severe stroke and reversible cerebral vasoconstrictive syndrome? I did have one patient with definite RCVS after a monoclonal antibody, after CGRP. Pulmonary hypertension can be increased. CGRP is good for those with pulmonary hypertension. We do see a lot of CNS effects, and this is a quandary. Why? We see anxiety, depression, fatigue sometimes, insomnia, irritability, sometimes increased headache. One possible explanation, the blood-brain barrier is not really adequate in certain areas. The area postrema, these circumventricular organs around the ventricles. So the area postrema is crucial in nausea and hiccups. And I've seen a couple cases that I think were due to the CGRP meds. Part of the hypothalamus, the posterior pituitary, the pineal. So we don't get much penetration of the CGRP mAbs formally. You usually need more penetration, significantly more, to have a clinical CNS effect. But maybe we're getting an effect also through trigeminal vascular pathways or downstream. CGRP, though, is ubiquitous, not only through the CNS, but most organs. And we've not seen adequate hormonal studies or almost any hormonal studies. And they're starting to be used in studies anyways in children and adolescents. And I have used the CGRP monoclonals in some adolescents who are very refractory, but they really haven't been tested. Outside of hormonal, the long-term effects of these in children and adolescents, as I'll mention in a minute, CGRP is important for bone formation, and we just haven't tested them in this age range. CGRP is ubiquitous throughout the GI system. It helps in various things: motility, mucosal protection. So constipation is particularly bad. Probably more with erenumab. We've also seen diarrhea. Whether ulcers are more difficult to heal, it's not been looked at. And there's a lot of questions. Should those with inflammatory bowel disease maybe be excluded from these drugs? CGRP is crucial for tissue and wound healing. That's not been looked at. Skin regeneration, thermoregulation, and very importantly, burn healing. What if somebody gets a moderate or severe burn and they're on a CGRP? These monoclonals are in your system. The half-life is 28 to 30 days. The half-life of the Gepants, Rimegepant, Atogepant, Ubrogepant, are really 12 hours or so, and you're not taking them every day. So I'm not so worried about that class. These are large molecules. The Gepants are small molecules. So CGRP does have an important role in bone metabolism and new bone. Dialysis could be a problem with CGRP. It's protective for kidney disease and during sepsis. So you're getting the idea from head to toe. We're blocking a molecule. Sure, it does good things for headaches, and I like that, and we use them. But we do have the negative factors that have not been looked at. CGRPs in the pancreas. How about effects with diabetes? Now, pregnancy, the effects are unknown. In theory, it's possible that CGRP blocking and the monoclonals might be worse later in pregnancy with cervical ripening, et cetera. As you know, with pregnancy, we look at several factors. We look at immediate effects with birth defects, cardiac, and craniofacial. And then over the next 18 years, we look at ADHD, we look at behavior, we look at IQ. So medicines such as valproate, for instance, sodium valproate, valproic acid, increases all of these. It increases the risk for birth defects, but also, and depends on what dose, but IQ is lower. We have behavioral issues, and we have increased ADHD. Even acetaminophen, Panadol, ADHD is increased with frequent acetaminophen use during pregnancy. So we just don't know. It's going to take a while. Eventually, we did get information, some on the triptans, and there's been pregnancy registries going back to the 90s on sumatriptan and naratriptan. And these do appear to be relatively safe. So certainly during the second trimester, sometimes we use these. But the CGRP meds, it's going to take decades to figure this out. CGRP also declines with age. And are we going to have more risk after age 70 or so with cardiovascular? Now, the studies really missed the adverse effect profile. The CGRP studies came out, the phase 3 studies, with clean package inserts, very little, just hypersensitive reactions. And as I'll mention, we've seen many, many side effects. And how did this happen? So after a drug comes out and is approved, how do we piece together the true adverse effect profile? And I really am focusing more on adverse effects, which is what is reasonably, that we think is reasonable from the drug, that the drug actually caused, as opposed to adverse events, which is anything on that drug. So that's why you see a lot of package inserts with headache and upper respiratory infection from a drug, even though it's not causing those, it's adverse events. But I think adverse effects are much more important. But after the drug comes out, we look at the websites of the European FDA type and Canadian and United States, post-approval studies, high prescriber chat boards, which I think are very valuable, and patient chat boards I'll mention. They're not worthless at all. Our personal experience, of course, if we're a high prescriber, and correspondence and meetings or with other patients and physicians. So we piece it together. So it's been 5 years now. We have data from the FDA through end of March of this year, and we have 67,000 adverse events. This is about the largest number of any class that I know of that's come out. Serious, though, is almost 10,000. So serious, there are several definitions. Life-threatening or hospitalization is one definition, or something requiring intervention. And one expert has done some research. He felt that only 1 to 7%, 1% is more common, of serious adverse events are actually reported. So we don't know how many, but this is a lot. These numbers are actually about the same as onabotulinum toxin for 30 years. So we have 30 years of onabotulinum toxin. The events reported are about the same as the 4 years of the monoclonals. Very high numbers. Now, irenalimab has the most, but I don't think that irenalimab really is any more or less safe or more dangerous or anything than the others. It just was the first out, the most reported. And I do think that constipation's more with irenalimab, but the others are catching up a little bit. Constipation can be pretty severe with irenalimab, and of course the studies missed it. Now there's a warning in the package insert. I think the companies do a good job. The studies are run by contract research organizations. The problem really lies, and I'll mention why, in how we acquire these adverse events during the studies. And that has to change through the organizations like in the United States, the FDA. So post-approval, we look at studies. We did out of our office a checklist study where I think if we don't use a checklist, we're going to miss the adverse events, adverse effects, which is going over common signals or probable adverse effects from a drug with a patient. So we took patients and we asked them in the usual way that studies ask them, 119 patients on the monoclonal antibodies. We asked them, well, how are you feeling? Any side effects, any problems? Are you tired? And then we presented a checklist of 18 very well-defined possible adverse effects, or signals, as they're called. And we went over each of them. And if patients said, oh yeah, I have joint pain. Oh yeah, I have hair loss or muscle aches. We then went over the history and what happened to make sure that it was from the monoclonal antibody. And what we found was that 66% of the patients had at least one adverse effect that was not revealed upon the initial questioning. So if you don't use a checklist, and the studies don't, you're going to miss them. We had a number of patients that had more than one and multiple adverse effects using a checklist. Another avenue to explore is real-world experience. There's been some studies, we need more. Robley et al. Did not find all that many adverse effects, but they did have 12 discontinuations due to adverse effects out of 118 patients. Another study did find a very high degree of non-serious adverse events. And there was yet another study that did not show that many discontinuations. So it's been a mixed situation with mixed results. We need more real-world experience from high prescriber clinics looking at, say, 500, 800 patients. So I think most studies miss the adverse effect profile. Efficacy holds up pretty well. This is not unique to the CGRP monoclonals. The companies are doing reasonably well with the studies. It's just we need to change. So the signals that are in the package insert now, hypertension is emerged as a signal, and the monoclonals seem to increase blood pressure, maybe 3 points, maybe 4 points. That's significant. And if it's a little bit more in one individual patient, that can be significant over 10 or 20 years. I quote a leading expert in acquisition of adverse events in clinical trials. Thomas Moore was considered one of the United States leading experts, and he was astounded when he reviewed these several years ago at the sheer number of adverse events due to the monoclonals. We also look at physician communications on our chat boards. We have one chat board with maybe 400 providers that's very active. And I look at what they say. For instance, one emailed me that they were giving a monoclonal. It was actually the doctor's wife, and she had very severe nausea and vomiting right after going on the monoclonal, had several negative workups. And I said, it's probably the area postrema syndrome. But unfortunately, with the half-life of the monoclonals, it's going to take months, may take 5 months to completely get out of the system. Interestingly enough, patient chat boards, we looked at almost 3,000 comments and parsed them out, identified 490 highly believable comments. Highly believable would be, I'm 58 years old. I never write on chat boards like this. I've never had depression. I went on one of these injections and I've been severely depressed. And I went off and the depression went away, and I went back on and the depression came back. That's a highly believable comment. Interestingly enough, the adverse effects of these patient chat boards lined up really well with our other sources, like the FDA and the studies, et cetera. So in our experience, we've seen a large amount of non-serious ones. In 25 years, 27 years actually of using onabotulinum toxin almost every day, I've had only a few adverse effects, no serious ones. But in our little clinic here, we've had 4 or 5 serious adverse effects from the monoclonals. Early on, we had a 21-year-old with a stroke. She can't write, she has agraphia. A 61-year-old with reversible cerebral vasoconstriction syndrome. Another older woman with severe joint pain, she had to be hospitalized. And then a curious 30-year-old with a number of symptoms. They resembled multiple sclerosis, but it required 2 hospitalizations. Patient communications also, they email me, patients all the time. I get emailed because of our blog, et cetera. And they say they've never had problems like severe joint pain or muscle pain, and now they are from the monoclonal. So I do listen to these patients' communication. Obviously, it's anecdotal. So putting all of these lines of evidence together are signals that have emerged, I think, in order of frequency from the monoclonals. Constipation, number one, maybe 20, 25% of patients. Anxiety, injection site reactions, insomnia, hair loss, joint pain, muscle pain or cramps, irritability, depression, increased headache, nausea, weight gain, hypertension, and sexual dysfunction is classically minimized in studies. People don't mention it. They don't bring it up. So you actually have to ask about it. And sometimes, you know, it's been reported tachycardia, rash, diarrhea. So the problem is the studies don't use a checklist. I'll go over each of these in a minute. They're underpowered for number of patients and for time. Symptoms become disaggregated. The patients tend to be milder. And the patients they have less comorbidities in studies. So without a checklist, you're going to miss the studies. Miss the adverse effects. The studies are underpowered for number of patients. So if you have 1 in 1,000 patients with a true adverse effect, you need 3,000 patients to uncover one case with a 95% probability. And to uncover 3 cases, you'll need 6,500 patients. And most studies have 500 to 1,800 patients. They don't have these numbers. In time, we really need years of study. And the long-term extension studies, I think they're cherry-picked because the patients are doing well, so they're not going to show anything. Symptoms become disaggregated. So you might say you're fatigued. I have malaise. The next patient has somnolence. Each of these might be 1 or 2%. So it gets really not reported. But when the true incidence, we're all talking about the same sort of feeling might be 4 or 6%. You can re-aggregate after the study, but that's fraught with problems. Several years ago, I presented slides like this in Controversies in Neurology. Before the debate, 94% of the audience, this is international audience, thought that these were very safe. And after the debate, only 42%. So it shows we need to be doing a better job of telling physicians and providers and neurologists that these possibly have these side effects so that patients don't go there, complain about hair loss or muscle or joint pain, and they're dismissed and minimized, and they're told that it can't possibly from the drug, so they continue on the drug. In real life, these monoclonals have had a lot of side effects, and they tend to be minimized by the providers. The efficacy is held up well. I like the drugs. It's just, where do we use them? And I do feel they should probably be used after a few other medicines haven't worked, our traditional medicines, and ideally on a botulinum toxin, which isn't available everywhere, I know. But what I do see now is that a lot of patients are going on these drugs, on the injections right away before they've tried anything else. We do also need our trial experts to change how adverse effects are collected in studies. So we're talking about short-term safety. Long-term safety, we don't know. And sometimes it takes 20 years or 30 years, as you know. I think these are going to stay on the market, but I think more is going to come out over time. And lastly, evolution has decided that CGRP is important in most systems for many, many years, and we're blocking it in young people and sort of closing our eyes, hoping that nothing bad happens. And I always say we ignore evolution at our peril. And for that, I want to thank you. And we welcome any comments or questions.